Okay, so as our week begins, this is going to be going to talk about in week 4. We're talking about intervention, evaluation, pain management, and wound care. We're going to go ahead and start with pain management, which is found in chapter 43. So, why is pain so important? Pain management is very important, as we know. It is now, for some time now, it's been considered the fifth vital sign. It is something that is considered very subjective, so only the patient knows the extent of his or her pain. It can cause a lot of distress and affect personal relationships, especially when someone has chronic pain. They're unable to fulfill their ADLs because they're so uncomfortable, which can affect their personal life and relationships. So, as nurses, we need to understand factors that contribute to pain. We have to do comprehensive pain assessments, and we have to develop nursing interventions to relieve our patient's pain. We also, no matter what we think our patient may be going through, we can't be the judge of their pain, and regardless of how they appear, as you know, on some of you that have medicated patients before, some of them may look very comfortable as they're requesting their pain medication, but at the same time we are not 100% sure what's going on internally. So some people have just learned to live with the pain, but at the same time it doesn't mean that they want to sit in our during our care and be uncomfortable. And the good thing is, if we do achieve our patients comfort, they're going to go ahead and trust us. They're going to increase their activity, which is always what we want our patients to do. We want them to be up, walking around. It's going to reduce their hospital stay, and if we are able to send them home with a proper pain medication regimen, it's very unlikely that they'll come back because they're going to be comfortable at home. So those are some of the important things that we need to focus on as we handle our patients' pain management. Some of the physiology that has to do with pain, it all begins where our body senses damage to tissue. At that moment, there will be mediators that are released. These are bradykinin, histamine, and prostaglandin. These substances will surround the pain fibers in the extracellular fluid. They're going to send the message. They're going to begin with an inflammatory response. Pain impulses go through the spinal cord to the thalamus, which at that time transmits information to our brain, letting us know that there is an injury, there is pain, and that's how we perceive the pain. There's two types of sensory nerve fibers, and you should have learned this when you took physiology or pathophysiology. We have the fast, which is myelinated. That one will send sharp, localized, distinct sensations. And you also have the slow nerve fibers, which is the unmyelinated. Send poorly localized, burning, persistent pain, and this is more of a slow message. Physiology of pain. A patient who is experiencing pain cannot discriminate between these different 4 factors. You have energy of these pain stimuli is converted to electrical energy, and during transduction, the pain production stimulus sends an impulse across the sensory peripheral pain nerve fiber, which is also called a nociceptor, and that's beginning in the transmission of pain, which is phase 2. Perception is a point at which the patient experiences pain when it is received in the brain. Psychological and cognitive factors interact with physiological ones in the perception of pain. The recall of the pain is not just in one single pain center, can go into phase 3. Once perception occurs, there's a inhibitory neurotransmitters are released, which is described as the modulation, and that is also known as phase 4. At that point, there's inhibition of the pain, and at that point, it's phase 4. Physiological response occurs when pain impulses ascend from the spinal cord towards the brainstem and thalamus, as we talked about in the previous slide. The autonomic nervous system becomes stimulated, plus triggers the fight or flight system. That's when the heart rate goes up, respiratory rate goes up. So we have different changes that occur when our fight or flight reaction occurs. A little bit more on physiology of pain. You have the gate control theory of pain by Melzack and Wall. The gates can be physiological, emotional, and cognitive processes. You gain a useful conceptual framework for pain management by understanding the physiological, emotional, and cognitive influence on the gates. Things such as stress and exercise increase the release of endorphins, often raising an individual's pain threshold, which we know that our threshold is the point at which a person may actually start feeling pain. Because the amount of circulating substances varies per individual, the response to pain varies. So does that begin to make sense on why different people experience different levels of pain? And we have different types of pain here. We have nociceptive and neuropathic. With a nociceptive, that results from stimulation of pain receptors at different sites. Can be from trauma, ischemia, and inflammation. Some of the visceral pain can come from internal organs such as labor pain, angina pectoris, irritable bowel, things like that would be considered visceral pain. Then on the other hand, you have somatic pain, which can be from skin, connective tissue, bones, and muscle. Somatic pain can be from a paper cut or a sprained ankle. When patients describe this type of pain, they'll describe it as it's pounding, aching, and dull. Then you have neuropathic pain. That results from an area that is exposed to repeated transmission of pain signals to an area of injury that may have been affected nerve cells. Neuropathic pain can be like diabetic peripheral neuropathy type of pain. It's chronic. Can also be phantom pain, and as y'all are aware, phantom pain can come from someone who has had a amputation and continues to experience pain to a leg that no longer is attached to the body. And what that is because the body itself, because the nerve endings are not they're not aware yet that the other part of the leg is missing. So at that point, they'll still trigger some pain to that area. And the way that patients describe this type of pain, they'll usually say it's some kind of pins and needles, burning, numbness. That's how they describe that kind of pain. And then you have acute and chronic. And with acute, we know that it is new. It hasn't been around for a long time. Acute pain can come from surgical procedures or maybe a pain that is temporary. We know that once it's healed, pain itself is going to be gone. It can be mild or severe. It just depends. It's individualized. And this can cause a sympathetic nervous responses, which mentioned before in previous slides, where it'll increase your heart rate, your respiratory rate, your blood pressure, your pupils become dilated, you can become diaphoretic. Then on the other hand, you have chronic pain. With chronic pain, it's long duration of pain, which is greater than 6 months. It is constant and recurrent. It can also be mild to severe. It just depends on the individual. It can be ongoing and persistent beyond tissue healing. In other words, once the tissue is healed, it is still going to be painful. So that's why we call it chronic pain. And with this, because the body is so used to having it, at that point you have the parasympathetic nervous system that is involved. So there may not be changes in vital signs. So sometimes when we have these patients that have extensive chronic back pain, we're looking for changes that we would see on acute pain, but remember, it's a chronic type of pain, so you're not necessarily going to see these changes. And many of your clients, because they're always in this constant discomfort, many of them are depressed. So things that we need to know. Unfortunately, with a lot of healthcare providers, they feel that if the patient is not showing any objective signs of pain, that he or she is just a complainer or a malingerer. So it's important to not make assumptions about the patient's pain, not develop any kind of biases based on culture, education, experiences. Acknowledge that pain is through the patient's experience, and if you develop biases or you have other perceptions of what their pain should be, it's going to limit your ability to be able to help this patient. So it's important not to go in with a different type of thoughts in your mind in regards to the patient's pain, and just be open to give them whatever pain medications they need. As I always tell everyone, do not hesitate to medicate. You have an order. As long as the patient's vital signs are able to sustain narcotics or whatever type of medication you're going to give them, then you're okay to medicate. Remember, the patient is the only judge of his or her pain. Some factors influencing pain. Pain is very complex, and it can take a holistic approach. You need to take, like I said, holistic approach to help meet the needs of your patients. Age can influence the pain experience, especially in the young and the very old. These people tend to be less expressive when it comes to pain. The genetic makeup can also affect a person's pain threshold or tolerance. Factors such as spinal cord injury, peripheral neuropathy, and any kind of neurological diseases can also affect a patient's response to pain. A patient's attention to pain, previous experiences, social support systems can also affect their pain experiences. It's important to also keep in mind different kind of cultural backgrounds. Some cultural backgrounds tend to be more stoic versus others are more expressive. Make sure that you always educate your patients, let them know that proper pain comfort and pain medication, as long as it is within their orders and they're going to be comfortable while they're hospitalized, it is very important because they don't want to prolong their stay. We don't want them to have unnecessary due physiological stress. We want them to get up, move, and exercise. Some of them may even bring religion into their reason why they want to have pain. Some may even say, "Why has God done this to me?" So there's going to be different things that your patients will tell you. So there's other ways of getting across through that. There's always hospital chaplains and people that you can consult with to make sure you provide your patient with the best possible care that's out there. The nursing process and pain. Pain management needs to be systematic. Successful pain management will depend on how well you establish trust with your patient and their family. If you're able to gain their trust because you are ensuring that they're comfortable, they will trust you. The goal of pain management is to anticipate and prevent pain rather than to treat it. So we always want to inform our patients to let us know immediately as soon as they start becoming uncomfortable so we can medicate them before the pain becomes out of control. We want their thresholds to remain low so when we medicate them, they're able to stay within a comfort zone. And we know that pain is a fifth vital sign, so it's very important that we make sure that their pain is under control. It's also one of those questions many of us are being monitored with. When the patients go home, they have this questionnaire: was your pain under control while you were in the hospital? So how are we going to assess our patients? We're going to assess every time that we medicate. We need to know where the pain is, the location, how bad is it, type of quality is it, burning, sharp, throbbing, the pattern, anything that they do that can relieve it. Sometimes you can simply reposition a patient and that can help relieve their pain. You can give them music therapy, especially you can try different alternatives if it's not time for them to receive any pain medication. So always remember those other things that are out there for our patients. I think that's all. And always make sure you go back and you follow up all of your patients' discomfort. You want to make sure that you are making sure that your current pain regimen is truly helping them out with their discomfort. This one here is just a sample of the pain scales. This one here is a numeric pain scale, which many of you are familiar with. Then you have the Wong-Baker faces. This one is good to use with your nonverbal patients, can also be used with your pediatric patients. So more on assessment, we want to make sure that the effects of pain on our patient, what kind of behavioral effects are they having? Are they able to have a vocal response, facial and body movements? What is their social interaction? And then how is this influencing their ADLs? If they're comfortable, very likely they're going to have more physical deconditioning. If they're uncomfortable, it's very rare that they're going to want to get up and walk or do that IS. If they're uncomfortable, at the same time, they're also going to have sleep disturbances because they're not going to be able to get rest because they're constantly uncomfortable. And then this is more as an outpatient basis. How is this affecting their sexual relationships? How about their ability to work? Are they able to work during the day as they go through this different kind of discomfort? Those are things we want to assess for because we want to find medications that are going to help the patient. So pain assessment and management. We want to ask about pain constantly throughout our shift. You should be asking about pain at least every 4 hours on a 12-hour shift. You want to be able to believe the patient and the family. Whatever they say, we want to believe on what they've tried before and what relieves it. Choose pain control options appropriate for your patient. So you're not going to pick some type of pain control or you're not going to recommend. You will work with your physicians with this. You're not going to recommend, let's say, like a long-term type of therapy for a patient that's having acute pain. So you want to use some critical thinking when you're choosing pain options. And deliver. Make sure that it's being delivered on time. And you have some kind of consistency with delivery. Perhaps every 4 hours, PRN as needed. Do they need any breakthrough pain medication? So those are the kind of things you want to think about. Okay, and with this question, when a smiling and cooperative patient complains of discomfort, nurses caring for this patient often harbor misconceptions about the patient's pain. Which of the following is true? Remember, the answer to this is B, because patients are always the best judges of their pain. Here are some of the nursing diagnoses associated with pain and discomfort. Planning. So as we plan, we want to determine what the pain has prevented the patient from doing, inpatient and outpatient, because we don't know where we're going to be practicing, so we have to look at different scopes. When managing pain, our goal is to make sure we're promoting a patient's optimal function. We want them to get up and walk, do their ADLs. When we're setting priorities in pain management, you want to consider the type of pain the patient is experiencing and the effort that it has, excuse me, yawning, that it has on varying body functions. Work with the patient to select interventions that are appropriate. You want to include them in the plan of care. When you include your patients in the plan of care, more likely than not, they're going to follow the pain regimen. Make sure that we're measuring their pain relief as well. If you give an IV medication, you should be reassessing anywhere from 15 to 30 minutes. If you give an oral agent, you should be going back to evaluate anywhere from 30 minutes to an hour. Implementation. As mentioned before, that there's other types of therapies out there. There's non-pharmacological pain relief interventions, which we can use guided imagery, relaxation, music, distraction. There's TENS units, heat and cold. So pain therapy requires individuals, and it's individualized approach. Remember, every patient is going to be different. It's significant for our patients to try to understand their pain. When they understand their pain, it is more likely that we can help them with their pain. We can try different types of techniques. Not all therapies will benefit individual patients, so we need to try different things. Things such as relaxation and guided imagery, these help patients alter their effective motivational and cognitive pain perception. Relaxation is something else. It's mental and physical freedom from tension or stress that provides patients a sense of self-control. Distraction also helps. Along with music, there's evidence out there that shows that music decreases the use of analgesics in some post-op patients. That usually works more with acute type of pain. And then you have the gate control theory suggests that constant cutaneous stimulation activates larger, faster transmitting beta A sensory nerve fibers, which means that it closes the gate. When the gate is closed, that means that the pain has been decreased. There's also massages. Careful with that. You don't want to be massaging legs on post-op patients. You don't want to release a clot. Herbals, chamomile, things that help the patient relax are all good options. So implementation. Now, we talked about non-pharmacological. Now we're going to talk about pharmacological, which would be your medications. You have your analgesics, you have non-opiates, opiates, and you have different types of delivery systems. You have a PCA pump, which is patient controlled, and then you have local medication, and you have topical agents. With post-op patients, many of them will work on their pain management with anesthesia. Some of them may use things such as epidurals, but we're going to talk about that as we go on in different slides. One of the best ways to keep your patient's pain under control is to give them pain medication around the clock. You will have at times patients who come out with orders suggesting them to have medications around the clock rather than just as a needed basis. And the problem with PRNs is that some of our patients will wait till their pain is excruciating before they ask for something, which at that point is going to be harder to control the pain. So if we're giving something around the clock, they're always going to be comfortable, and it's actually less likely that they're going to need something in the PRN, although they may still have PRN orders or breakthrough pain type of orders. Analgesics are the most common methods of pain relief that we use. And then we have non-opiates, which would be your NSAIDs, your acetaminophen, your Tylenol, your Motrin. These are for mild to moderate pain relief. And most NSAIDs will work on peripheral nerve receptors to reduce transmission of pain stimuli. But caution your patients. Long-term use can cause GI bleeding and renal insufficiency, and long-time use of acetaminophen can cause liver injury. So everything to be used with caution. Opiates are prescribed for moderate to severe pain, but also keep in mind that these can cause respiratory depression, adverse effects of nausea, vomiting, constipation, itching, urinary retention, and altered mental processes. Sedation is an adverse effect of the opiates, so we want to make sure that our patient is not completely snowed. We want them to still be able to function and do their ADLs, so we don't want to over-medicate either. Now with the PCA here, these are infusion pumps that are portable and they're computerized systems that are programmed by a nurse and is verified by a secondary nurse. These systems are wonderful because the patient is able to self-medicate. They have full control. Patients that are post-op do really well with this type of pain relief medication. However, the patient is the one that has to push the button and not family members and not healthcare providers. These pumps do have a safety lock system, and they also have lockouts. They can be anywhere from 5 to 15 minutes. So it's when programmed correctly and used as recommended, this is a very safe pain medication system. Here is now a picture of epidural spaces. With this one is a type of medication that you get here is epidurals. Women that have babies will get epidurals, and then you can also have pain relief through epidural injections, so spinal epidural injections. And this is done by an anesthesia specialist, can be either a nurse anesthetist or anesthesiologist. So although we do not insert these systems into our patients, we are 100% responsible to monitor the machine itself. Many of them will be connected to a machine that looks somewhat like your PCA, but will be different colors to prevent errors from occurring. You are responsible to monitor the medication that is infusing into your patient. So you need to know what side effects are you going to be looking for, what are some of the reactions, and what should you have at the bedside. With most of these medications, you should always have an order for Narcan because you want to have an antidote ready to go if your patient starts having negative side effects from the medication. Implementation. As you administer pain medications, remember that you are responsible for monitoring the patient's pain relief. You want to make sure that their pain relief is effective. You want to make sure that there's no adverse reactions. And you should also, once again, you want to have Narcan at hand to administer it whenever needed. And premedicating patients before painful procedures is always important because your patient will be able to cooperate and it will reduce their experience of pain. Always check your healthcare facility for policy and procedures when you do this. Here's another question. A patient has just undergone an appendectomy. When discussing with the patient several pain relief interventions, the most appropriate recommendation would be you should have selected D, PCA, because this is going to be post-surgical, which I mentioned that is an effective way of managing their pain. Another thing I would have wanted to know is the age of this patient, and to make sure that they are, I say age only because I want to make sure that I do not have a demented patient. Patient has to be able to cooperate and follow instruction in order to be candidate for a PCA machine. Now, with cancer pain, remember that cancer pain is not, it's going to be more chronic before it's acute, although there is patients that do suffer acutely from cancer pain. It just depends. And the way we treat cancer pain is very different than the way we would treat other types of pain. If a patient is well medicated, it is very unlikely that he or she will develop any type of addiction. They actually have estimated that when it comes to cancer pain, addiction will only occur anywhere from 6 to 10% of the population, which is a very small number considering how many of them are taking very strong analgesics. You want to treat these patients with long-acting or controlled release types of medications, like your sustained release or long-acting. Most chronic pain can be managed with oral medications and patches. So with transdermal patches, keep in mind that they are 100 times more potent than morphine and provides good pain relief for 48 to 72 hours. This route is selected when a patient is unable to take oral medications or if they need that additional pain relief. Transmucosal fentanyl is used for breakthrough pain. The fentanyl is swabbed into the mouth, so there is a transmucosal fentanyl. When severe pain continues, despite what you do, many invasive interventions are available. So there are, look at your figure 4314 in page 987 will show you more diagrams on some of this pain relief. The ladder of anesthesia or analgesic. This is explaining to you how you go through the ladder. And if you can see at the top of the ladder, you want your patients to be free from cancer pain. And this three-step approach is something we use for our cancer patients. We want to begin treatments with NSAIDs and adjunct therapy, and then as the pain gets stronger or unable to be managed with analgesics and NSAIDs, analgesics, with NSAIDs, then you want to go up to stronger medication, all the way up to opiates. So what are some of the barriers to pain management? At times, healthcare providers do have problems with thinking their patients are going to be addictive. And some healthcare providers will actually alter the use of the medication. So the doctor has ordered 4 milligrams, but they'll say instead of 4, I'll give them 2. We really are legally, that is not a practice that is supported through. That is actually, it's not supported through the Board of Registered Nursing, and it would be considered practicing medicine. If you feel that 4 milligrams perhaps is too high of a dose for your patient, what you want to do is you actually want to call your doctor and modify the order. Have the doctor maybe have an order for 2 and 4, but you cannot do that and go and waste the other 2. You are modifying a medication that you do not have an order to modify. So you can be in serious trouble when it comes to your licensing. Other things is addiction here. A primary chronic neurobiological disease with genetic, psychosocial, and environmental factors. There's a lot of things that come with addiction. Not every patient will get addicted. Sometimes some are at higher risk than others. Addiction rarely occurs in patients who take opiates to relieve pain. Addiction usually starts when they're taking too high of pain medication for a small level of pain. The medication has to match the level of pain. You can't take a morphine sustained release when all you're having is a simple little ankle pain. For that, you just can take Tylenol or NSAIDs. Addictive behaviors include one or more of the following. You can have impaired control over drug use, compulsive use, continued use despite harm and craving. Placebos have been used before, not in acute care. Placebos are medications or procedures that produce positive or negative effects. This is something that should never be ordered. If a placebo is ordered, you need to question it, because we are not allowed to tell the patient we're giving them something and then it's just a placebo. Professional organizations discourage the use to treat pain. Placebo use jeopardizes the trust between your patient and us, the caregivers. So, not something you would want to find in your MAR. Restorative and continued care. A comprehensive pain center treats people in an inpatient and outpatient basis. And if you have someone in-house that is going through a lot of discomfort, there's also many hospitals have what they call a pain team, which is a team of doctors and nurses that specialize in treating chronic pains or pain that is difficult to control while someone's hospitalized. Going back to comprehensive pain center that treats persons or inpatient and outpatient basis. Staff members representing all healthcare disciplines. You have everything from nursing, medicine, pastoral, physical therapy. There's a team that's going to work with patients and find the best effective pain measure. Sounds very much like the pain team, other than this is in an outpatient basis. A comprehensive clinic provides not only diverse therapy but also research into new treatments and training for professionals. Many hospitals have palliative care departments, and this is for someone that is going to need discomfort as they go through palliative types of treatments. Remember the difference between palliative and hospice. With palliative, it is someone who is living with an incurable condition. Let's say someone who has end-stage congestive heart failure. This person is going to need a heart, but let's say it's an 89-year-old patient. We know that they're not going to get a heart. They're at high risk for transplantation. So what we do for this person is we don't want them to continually be hospitalized and be uncomfortable getting poked and probed. So what we're going to do is we're going to manage them through palliative care. So they live to learn fully adaptable lives with an incurable condition. This is someone who is going to live longer than 6 months. Now, when it comes to hospice, now we're treating someone who is terminally ill, someone who is going through perhaps a stage 4 type of cancer, cancer that is inoperable. It has already metastasized, and this person is going to live less than 6 months. With hospice, this is someone who opts to be hospitalized and they want to be in the comfort of their own home. And at this point, the goal for hospice nurses is pain control. So this is under the guidance of hospice nurses. We teach families on how to monitor patients for signs and symptoms and how to be able to medicate them. Now, once someone goes in hospice, they're not supposed to be getting hospitalized or calling 911. Because at this point, all we want for this patient is comfort. Does it happen? All the time. We all have patients who have been on hospice programs, and then family gets scared and they call 911. Next thing you know, this patient's in the hospital with a breathing tube. And because they have a terminally ill disease, they actually end up dying in the hospital with tubes and getting poked left and right. As long as someone is a full code, we have to do everything possible to save them. And remember, this is a terminal disease. No matter what we do, we're not going to save them. But we still have to respect the wishes of the family. Hospice programs do help nurses overcome their fears when they contributing to patients' death when administering large doses of opiates. There are many nurses out there, many, I know a few, who are not comfortable when we do end of life in the hospital. Let's say I'm using this this example of this patient who was on hospice. Family got nervous, they called 911. Now this patient is in the ICU on life support. Because they're full code, we have to continue doing everything possible to save their life. That means we are coding them. We are breaking ribs because many of these people are frail. Now it comes to a point where the family says, okay, enough is enough. We want our family to go comfort. So When we go comfort, we have large doses of opiates that we give them. We put these patients on a morphine drip. We're giving Ativan or Versed IV push because we don't want them to remember, because what we call it is a terminal extubation. We're going to get the breathing tube out. Many nurses will allow this patient, they don't want the patient to die on their shift, so many times they're not going to give the necessary large doses of opiates because they feel that they're killing the patient, kind of like a Kevorkian. So right now what we have is research that says that moderate opiate dose increases in patients who are terminally ill does not make the death go any faster. So for those nurses that fear, oh, I'm going to kill this patient because I'm going to give them 5 or 10 milligrams of morphine, there's a lot of research out there to say that not so. It's not going to make, when the time is there, the time is there regardless. So it's the disease that's killing the patient, not the opiate. Okay, here's another question. A post-op patient is using a PCA machine. You will evaluate the effectiveness of this medication when A, you compare assessed pain with baseline pain. B, body language is incongruent with reports of pain relief. C, family members report that pain has subsided. Or D, vital signs have returned to baseline. If the patient has chronic pain, along with maybe now they had an appendectomy and they have chronic back pain, that may not necessarily be, so D is not a good choice. We don't care about what the family has to say because the pain is what the patient says it is. Body language, maybe not so much. A is a better choice because we are comparing now to baseline pain. Remember, when your patient got admitted, someone asked this patient what was their tolerable pain level, and that's where our baseline pain level comes from. Checklist with our colleagues as we give report. If you have medicated the patient, you want to let them know when was the last time you medicated the patient, what worked for the patient, and what is the patient saying their pain is now. Is it acceptable? So let's say their tolerable level was a 3 and you have them at a 3. Is that acceptable? Yes, because you got them to the level that is acceptable for them. Which professional reference can be used if needed to support this recommendation? That just means that you have an order, or if not, then you want to call a physician and make a recommendation to help your patient's pain remain under control. Evaluation, what we do, we always go back and evaluate. Patients help decide the best times to attempt pain treatments. Ask patients about tolerance to therapy and the overall amount of relief obtained. If patient's state and intervention is not helpful or even aggravates the discomfort, stop it immediately and seek an alternative. I told you guys a story about my patient who had so much morphine IV push that I seriously could have knocked out an elephant. But that didn't work for her, and I called the doctor, reported this, and we were able to get her different types of pain medication, and luckily so that pain medication worked for her, and a tiny little dose of Dilaudid was able to relieve her pain. So we always want to evaluate. That's the most important thing when we're giving our pain medications, making sure that our patients are getting the proper pain relief and what is their response to this relief. Safety guidelines. The patient is the only person who should press the button to administer pain medication when a PCA is being used. So safety is the number one thing, along with making sure a patient's pain is under control. We also want our patients to be safe. To ensure the safety, you want to communicate clearly with members of the healthcare team, assess and incorporate the patient's priorities of care preferences, and use the best evidence when making decisions about your patient. One of the good recommendations for your patients, if they are in a PCA, is if you know that physical therapy is going to come see this patient, you want to let your patient know that perhaps they should get self-medicate before they come and try to get them up, so they don't push that button as soon as therapy gets there, but yet therapy is going to get them up now and they just push the button. It takes at least 15 minutes for this medication to take effect. So it's one of those things for time management and Time management, along with having a happy patient, you want to let them know the routines throughout the day. Also, monitor for signs and symptoms of oversedation and respiratory depression. If your patient is oversedated, that is not where we want our patient to be, so you need to make sure that you go and assess your patient, because that is a negative side effect of the medication. Pain management for the older adults. Unfortunately, with older adults, they tend to fall under a category of undertreatment. That's usually because they may not necessarily respond as quickly as someone that like a healthy young individual that has all the nerve endings are working correctly. And always keep in mind that pain is not considered part of the aging process. Due to changes to their nerve structure and their vascular changes, there's a variation of their pain sensation. Also, you might have patients that have dementia. They may have a difficult time expressing what they're feeling. A good principle to go with is start low and then go. So you want to start with low doses and see how that works. You don't want to give them a heavy duty dose and then have this medication stay in their system, because everything is slow, including the renal and liver function. So this may prolong the duration of action. And lab work for our elderly patients does need to be closely monitored, such as liver, your creatinine, your BUN, renal, your creatinine, your BUN, and for your liver enzymes. And a lot of the elderly, when they do describe pain, because they don't have this nerve structure such as the other people, a pain that may be for you may be incredibly just uncomfortable. An elderly may just say there's an ache. So the way they're going to describe their pain is going to be different than you or I would. Okay, so this concludes our pain lecture, and I will be doing implementation and evaluation in different PowerPoint presentations.